Looking at this chest radiograph, which is a frontal view, the first thing I notice is the contour of the left-sided aortic knuckle. It's clearly abnormal, showing what we often refer to as a figure 3 configuration. This is a classic sign of aortic coarctation, something that's important to pick up because it implies there could be a focal narrowing of the aorta just beyond the left subclavian artery. Now let's discuss the rest of the image. The mediastinum, aside from that prominent aortic contour, seems to be within normal limits. I'm not seeing any widening or abnormal soft tissue mass effect, which is reassuring. The lung fields are clear as well, with no evidence of pleural effusion or consolidation. The heart size seems normal, and there's no sign of left ventricular hypertrophy, which we might expect to see in long-standing aortic coarctation cases. When we come to the ribs, however, we see notching of the posterior ribs in the mid-thoracic region, particularly involving the 5th to 7th ribs bilaterally. This is quite typical for coarctation of the aorta. It happens because of the hypertrophy of the intercostal arteries, which serve as collateral circulation bypassing the narrowed aorta. It's worth noting that rib notching is a key finding to support the diagnosis, but we want to be cautious and differentiate between coarctation-related rib notching and other causes such as neurofibromatosis. Considering all of this, our most likely diagnosis here is residual aortic coarctation in a patient who might have undergone previous coarctation repair. But it's possible that despite prior treatment, there could still be a degree of stenosis or narrowing present. If an examiner were to ask what other differentials I would consider for rib notching, I'd mention that neurofibromatosis is a major one, particularly when the notching involves the superior aspects of the ribs. In coarctation, it's usually the inferior aspects. We might also think about venous causes, such as obstruction of the superior vena cava, though these are less common. Another question that might come up is how we would further investigate this patient. In this case, I'd strongly recommend cross-sectional imaging, likely a CT angiogram, to fully delineate the anatomy of the aorta and to determine the exact degree of narrowing. This would be crucial for planning any further intervention, whether it's surgical or endovascular. And before we move on, I just want to remind you, if you're enjoying these breakdowns and want to keep learning in this easy-to-digest format, make sure you hit the subscribe button to Radiology Made Easy. Drop a comment with any questions or cases you'd like us to cover next, and don't forget to share this video with your fellow radiology enthusiasts. All right, let's jump into the next case.